First of all, thank you to GIE for accepting our paper describing a novel powered 5.0 millimeter endoscopic debridement catheter for endoscopic transmural necrosectomy of pancreatic wall of necrosis. It was a case series conducted in patients from a tertiary referral center. My name is John Gásdal Karstensen. I'm an associate professor at the University of Copenhagen, and I'll give you a quick tour through the paper. The paper was conducted at Copenhagen University Hospital Hvidovre, where Pancreatitis Center East is located. So here we have a CT scan of a pancreatic wall of necrosis. Usually it is located like this, and it is easily drained, US guided transgastric. In some cases, drainage is insufficient to get clinical resolution, and in these cases it might be necessary to do endoscopic necrosectomy, which is usually done by a gastroscope. Here you can see the gastroscope is passing the stent, which in this case is a lumen opposing metal stent, and then you do the necrosectomy in the wall of necrosis, usually using snares, or in some cases baskets. We usually use snares, and it might in some cases be quite frustrating and also challenging because snares is not developed for doing endoscopic necrosectomy, but for EMR and polypectomy. In cases like this one, you can see that the one is extending all the way down to the pelvic area. In these cases, if you do snare necrosectomy, it gets very cumbersome to pass the scope all the way down transgastrically down to the pelvic area, grab the necrotic material, and then you have to go all the way back to the stomach to leave the material there, and then go back and forth several times. It might be complicated and especially quite cumbersome and time consuming. However, the endorotor might be a solution to this problem. A few years ago, a 3.0 millimeter catheter was introduced, and it was introduced mainly for doing EMR. Recently, a 5.0 millimeter catheter was introduced. It passes through a large working channel gastroscope. It needs a working channel of 6.0. It is designed for doing endoscopic necrosectomy, and it has a suitable diameter to do this in an efficient way. So here we have a movie showing how endoscopic necrosectomy looks like when we do with the endorotor 5.0. You can see that the necrotic debris in this case is quite a yellow, and this is really a goodie for the endorotor. Sometimes the endorotor, it has a lot of vacuum, so it might just collapse the cavity for a few seconds, but then you just insufflate some more air. You can see that you can all the time you are able to clearly visualize where you're working, and the risk of adverse events seems pretty low. It's a really controlled procedure. Our main aim of this paper was to evaluate the safety of the 5.0 catheter, and we only found one possible adverse event in relation to endoscopic necrosectomy. It was a presumed perforation of the one into the peritoneal cavity. He was treated with laparoscopic peritoneal lavage, and the patient recovered uneventfully. We also took a look at the efficacy of doing necrosectomy, and our median necrosectomy time per procedure was 60 minutes. The necrosectomy procedure was successful in 77%. There was one case where it was impossible to do the procedure due to excessive bending of the endoscope. Then there was a few malfunctioning of the catheter, and there was also 2 cases where we had clogging of the catheter due to solid debris. So there are huge perspectives in the endorotor, and the main aim is to develop a instrument which is efficient for doing necrosectomy, and we believe we have a really good solution for this. However, we still need evidence, and in terms of randomized trial comparing standard necrosectomy tools like snares and baskets with this new device. We don't have a really gold standard for a good necrosectomy, so we have to rely on clinical resolution, and that means we have to do sufficiently powered studies to compare them to modalities. So I thank you all for your attention, and in the end I want to thank GIE again for accepting our paper, and also want to thank my group at the Hvidovre University Hospital at Pancreatitis Center East. Thank you.